Good evening, ladies and gentlemen, and thank you very much for joining us for our complex PVC ablation tips and tricks for success webinar. We're joined by two very special guests that we have the privilege of joining us tonight. It's Dr. Siva Malparu, newly minted professor of medicine here at the Mayo Clinic College of Medicine and Sciences, and Dr. Abhishek Deshmukh, assistant professor and newly minted Rick Nishimura Teacher of the Year awardee. We hope to bring a great evening of joy, innovation, interesting cases, and have this very interactive. So something different. So work with us, and we hope you have a lot of fun tonight.
I will have the distinct pleasure of introducing Dr. Chris DeSimone, a phenomenal electrophysiologist and even a better and a most positive person you can ever meet. And I'm sure the whole vibe of this evening is to see how we can have a lot of fun and how we can learn from each other. The theme is really how if three friends are sitting together and discussing a complex PVC ablation, what we are going to chat about, that's exactly what we are going to discuss today among all of us who are here. Thank you, Chris, again.
Excellent. We have no disclosures. In our learning objectives, we've already showed you in the previous slide, but we want to encourage everybody to submit your questions live. This is going to be taped, so everybody just relax. It's 110 degrees outside. Feel free to have any cool beverage you wish. Very relaxed atmosphere. Anything that's unanswered live, we're going to either do through the webinar or through the taping, which will be up shortly, and we'll let all of our attendees know this via email. You could always at any time email the three of us, and all of our emails are up there if you have any questions after the talk. If you have any questions at any time in the future about electrophysiology, any cases you want to run by us, we're more than happy to discuss with you. So we really hope you have a lot of fun, and we'll get started. Briefly go over the learning objectives. One, and again, we want this to be something different, something that you haven't heard from before. And like Dr. Deshmukh said, it's exactly how if you were to come into the office with Siva, Abhishek, myself, and we had one of these conversations either before and after, and we learn from ourselves and really pick these cases apart and really milk them for all they're worth and give you really the tricks and practical approaches of how we look at these. We get a lot of referrals from outside, so sometimes second time, third time, fourth time redo PVCs. And we're trying to give you our insights to maybe have you be successful right off the bat, or when you're faced with those PVC redos. So we'll go over these cases. Again, we want aiming for quality, not just quantity. So if we don't get to all these, that's completely fine. But our aim is to go over peri-pulmonic region PVCs, LV summit region PVCs, as well as troubleshooting LV papillary muscle region PVCs. We're going to provide our insight, and we want to get your input and buybacks on this as well. And then we'll also discuss certain points where you have to be critically safe and critically focused in of certain things that we're looking at when we're doing these live cases. This will allow you to best optimize the efficacy and the safety of the procedural approach. And with that, we'll start with Siva on the first case of the evening.
Thank you, Chris, for the introduction, and welcome everybody to this webinar. This is a patient that I saw in the clinic. Patient is a 50-year-old male, basically coming to the clinic for new onset fatigue and tiredness. As you can see on this particular ECG, this patient is in a bigeminal rhythm, and you can see the PVCs don't have a preceding P wave. After the T wave, you don't see a deflection of a P wave. So you have a PVC, wide QRS, and then followed by a little notch in the T wave. That's most likely a retrograde P wave, resetting the sinus node. So you have a little bit of a pause there. And this pattern repeats. Many of us, when we think of PVCs, we are thinking about tachycardia, but I think it's important to understand why the patients have symptoms. It's not just palpitations or heart failure mediated symptoms. It's good to look at your arterial line tracings, especially when you're doing these cases, so you understand why these patients actually have symptoms. Okay, so In this case, you could see the PVC morphology is V1 to V6. It's almost precordial concordance, coming from somewhere near the base of the left ventricle. It's a right bundle, so coming from the left ventricle. And it's from the inferior wall, so it's negative in the inferior leads. So somewhere basal inferior left ventricle is what we're thinking when we look at this particular ECG. Any thoughts, Chris, Abhishek, when you look at this particular ECG, normal, healthy heart, young patient with new onset symptoms?
I think this comes up very often. And as you pointed out, the symptoms can be quite multifactorial. I also tell people sometimes is that, it's like having a bad back or a bad knee. You just get used to these symptoms and really don't know what it is to have a normal heartbeat. But based on the morphology, I agree that right bundle, kind of positive concordance from V1 to V6, lead 2-3 AVF being negative, so kind of inferior, 1 AVL positive, septal, so kind of LV inferoseptal type location. And other things I'm looking at is the coupling interval of the PVC. That looks pretty fixed here, at least to my eye. Maybe slight variation, but reasonably fixed, and a good retrograde conduction from the PVC. Now, Siva, in your experience, why do you think these people get really symptomatic? Is it the palpitations or fatigue, as you pointed out? How would you sort out in a clinic visit that the patient is fatigued from this PVC? Any tricks you can tell us?
Yeah, one thing, the patient is having bigeminy on an ECG in the clinic. A quick way to understand what his symptoms are is by checking a pulse at the time of the ECG. And if your heart rate, when you palpate the pulse, is half of what you're seeing on the ECG, those patients are less likely to complain of palpitations, but rather fatigue, tiredness, and shortness of breath. And I think the next 2 slides actually show you a correlate of what we see when we measure hemodynamic tracings.
Great. I also sometimes look at the carotid when I'm talking to them. And then exactly when I see a more carotid fullness, I ask them, did you feel that PVC? And sometimes they feel it, sometimes they don't feel it. But at least that also gives us a clue how really symptomatic they are from these PVCs.
Yeah, I agree with Abhishek. So when you're listening to the patient, I sit there and I don't let them know I'm listening to the PVC or listening for an extrasystole, but my eyes are also fixed on their carotid and see that. And then I don't say anything for a few seconds and I say, did you feel that a couple seconds ago? And then I really tease out what they're feeling. And then you kind of put that together.
Sometimes even taking them for a walk can help, and then feel their pulse intermittently. If the PVC gets suppresses with walking, then again, I try to ask them, are you feeling better? Are you feeling worse? Just to be 100% sure that, we are managing the symptoms of the patient, because a lot of times these PVCs are quite benign if the ejection fraction is normal.
Those are all great points. So let's move on to this is the same PVC. This particular patient ended up coming to the lab due to symptoms and similar superiorly directed positive concordance in the lab. And here is a coupling interval that we show. And when we actually have an arterial line tracing, you really don't have a waveform that corresponds to this PVC. And that explains why this patient has fatigue and tiredness rather than shortness of breath.
Great point.
Really fantastic slide. Sometimes, especially when getting access, the patient's in frequent PVCs, you'll see little jets coming out when you're getting access, and you'll know they're in PVCs just by looking. It's been apparent in some of these patients, and I found it quite fascinating. And then I would tell them afterwards, I really see why you were feeling the way you did, because basically every other beat or whenever these PVCs come, you're not perfusing the rest of your body, including your brain.
Yep.
One other trick I do in clinic, sometimes I just put the pulse oximeter on it, because that also shows you the oximetry tracing, and that also gives you a kind of a head start. The same principle what we use when we are listening, hearing PVCs in the EP lab, that tick, 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 tick is going. And once you lose a couple of, that sound, then you know that there is an extra beat or there is no extra beat and all those things. So just some simple clues what you can use clinically to see whether these PVCs are perfusing or not perfusing.
So lack of this arterial waveform can explain fatigue or tiredness, but this patient also continues to have shortness of breath. So in order to understand why these patients have shortness of breath, sometimes during mapping, you perform a transeptal puncture, and it's good to look at their LA waveforms. So here at the bottom of the tracing, we have an LA waveform here, A and a V wave. And similarly, for the last beat, you have A and a V wave. But when you have a PVC and that A wave, because of the retrograde conduction happens, you can see there's a marked increase in the LA pressure. That increases, pulmonary venous pressure, probably causing that subjective sensation of shortness of breath. So in this patient, that lack of waveform on the arterial tracing corresponds to the symptoms of fatigue, and shortness of breath can be explained by what we are seeing on the LA waveform.
Nice.
And some people call this mechanical bradycardia. So basically, electrically, your rate is fine, but just the mechanical, you don't have a mechanical perfusion. So something to keep in mind, not everybody has palpitations or sensation of tachycardia with PVC. So, and it's good to troubleshoot this in the clinic.
Exactly. And that's the same reason why the blood pressure machine at home gives an error, because all of them work on this optical sensor. And if the PVC is not perfused, the sensor is not picking up the signal and the machine gives an error or a false bradycardia. So same concept again.
It errs because it's just trying to average so many and things are falling out. So then it just quits out.
Great. So what did you do, Siva, in this case?
In this patient, we were able to map the PVC to the basal left ventricle. And once we ablated, his perfusion became normal. He's off medications. Clinically, he did well. But I thought it was interesting to show the arterial tracings and the LA pressure tracings for everybody to understand, to have a symptom and their rhythm correlate here.
Nice. In your experience,
nice,
Siva,
Siva.
because
Thank
you have
you so
been
much.
doing this for so many years, I didn't mean to call you old, but just you have been doing it for so many years. The location of this PVC kind of LV inferoseptal in a normal heart, does that make you think anything more? Or it's not your garden variety, say outflow tract or PAP muscle or one of these PVCs, right?
Yeah. So, this patient did not have any QRS abnormalities during sinus rhythm. On an echocardiography, there's no suggestion of any myocardial abnormality. If he had multiform PVCs, I would be looking for inflammatory heart disease or prior scar. But if it is just one morphology, monomorphic, fixed coupling interval, it's most likely idiopathic VT. You can have these PVCs. Idiopathic doesn't mean just outflow tract. You can have other areas of the heart. So if I didn't really have a big suspicion for inflammatory or scar-based disease in this patient. And with ablation, the patient did well, and we did not do further workup in this particular patient.
So the point being that if it's a single morphology, a fixed coupling interval, then even doing like more advanced imaging, cardiac MRI and all, if the preclinical suspicion is low, you probably won't be pursuing it, right?
That is right.
Yeah, same. I would do probably the same thing unless I find like a lot of abnormal signals when I'm mapping in that area. If I don't find that, then even post ablation, I probably wouldn't, explore more for any other inflammatory cardiomyopathy type situation.
And let's stretch that, Abhishek. That's great. So let's say you saw, and this is not uncommon, right? We get in there, we have just the echo, and then we get in and we do our mapping. We see lots more fractionation than you expected. What's your go-to imaging?
So I think the best imaging when you are already in the lab would be you can look at ice and make sure whether you are having any, kind of bright shadows, little bit of calcification or something which is not or more echogenic than usual what you are used to. But in those patients also after the PVC is done, I would do like a good V-stem to make sure we are not seeing any other re-entrant VT type situation, especially if we believe that there is some scar located. But certainly after the ablation is done, if again if my clinical suspicion is high, then I would consider getting a cardiac MRI or a cardiac PET scan if I'm concerned about sarcoid. But I think any good imaging, whatever is available in our institution, and we trust that imager is going to give us good result, I think I would get that sort of imaging done.
I agree. I like the cardiac MRI. And then if I really, really need to go further, I do one of two things. One, we'll move to the PET scan. Or if we're really there and we really have high suspicion, get a biopsy at the same time. I think if we do the ablation, sometimes we could be led astray. So we have to just be cautious with that. And if the patient's stable and doing reasonably well, what I'll do is when they come back in 3 months for a revisitation, I'll do the imaging at that time so that I don't falsely bias myself.
Great. Siva, there is a question for you. It says that the PVC is looking quite narrow. Can this be more Purkinje PVC or a fascicular PVC than a muscular or say myocardial PVC? And can it be a re-entrant beat with a short coupling interval? So just like narrowness and wideness of QRS, how do you account for that?
Those are both, there are separate questions there. One is narrowness, does it mean it's fascicular? So you can only answer whether it is fascicular or myocardial by doing high density mapping or doing really good mapping. You can have myocardial PVC with early engagement of the His Purkinje resulting in a narrow PVC, or you can have a fascicular origin with an exit causing a narrow PVC. So in this patient, after doing the mapping, it turned out to be myocardial PVC. There were no fascicular signals. The second question that Dr. Su asks is, can this be a re-entrant PVC? So in re-entrant PVC, you tend to find like very late signals, which we're going to show or discuss in our next case. Whereas if it is just a focal, you will find a very small area that is earlier than the PVC. So this turned out to be just a focal PVC and not a Purkinje based PVC.
Nice, thank you, Siva.
So Chris, there's one more question. What do you see if we have interpolated PVCs? What would you expect the hemodynamics to be like?
I haven't done hemodynamics during the time of a PVC, but I think with interpolated PVCs, you're going to have more desynchrony because that's coming in during normal contraction. So it's not what we're seeing on the screen right now with the PVCs where you have delay. It's kind of coming in between the both, because some of those are where patients could get even more symptomatic, or we think those are in theory more likely to lead to PVC cardiomyopathy.
Yeah, what I've seen is right after the PVC, your cardiac output is going to be lower, so may not have a higher systolic pressure, but after the normal beat, because of a relatively longer filling interval, your pulse pressure may be higher. Overall, interpolated ones, depending on the coupling interval, can be perfusing or non-perfusing. And it's dependent on the patient's EF, coupling interval, and the autonomic state.
Great.
One other trick I thought that was nice just going along this, if we're really looking at hemodynamics, sometimes when I've had these PVCs, I look down short axis on ice, and then I just put color Doppler along the aortic valve, and you could see the pulsations will change.
Nice.
All
right. So shall we go to the, yeah, there we go.
Okay, so this is another case, and it points out to, this is a elderly gentleman, a 70-year-old gentleman who comes with frequent palpitations. And in fact, this patient feels palpitations. His predominant symptom is palpitations, not fatigue or shortness of breath. Maybe I'll ask Chris or Abhishek to look at this tracing and see, describe us what they see and how they would approach this particular patient. This patient failed an AV nodal blocking agent, and he just came to the lab for an ablation procedure. And just to show, there is on the left-hand side of the tracing, we have an arterial line waveform, ECG leads 1, V1, V4. The right ventricular electrogram is on the top, followed by high right atrial electrogram. We have a His bundle electrogram. We also have a multipolar catheter in the coronary sinus, and we also have an ablation catheter in a region of interest at this point when the patient is having these PVCs.
Nice. So Siva, I think this is amazing tracing. So just, I'll tell you how I would interpret this, but I wanted to see, is this your typical workflow to put all these catheters, atrium, His, RV, CS, and all that, but we'll come to that. But at least the way I could, look at this, I know I can see lead 2 is positive. V1 has a small R wave and a left bundle morphology. And lead 1 is quite flat. I can't clearly see it, but being lead 2 positive, left bundle may be somewhere in the outflow tract. Now, based on the way your catheters are positioned, you have a RV catheter, a His bundle catheter. That His bundle catheter V signal is clearly late compared to the onset of the surface QRS. So that tells me it's not on the RV septum. Your distal CS, CS12 would give you some information of the anterior interventricular vein, great cardiac vein junction, cardiac summit, LV summit, left sinus of Valsalva, basically that ballpark area. And that also seems to be late compared to the surface QRS. So it's not LV summit, it is not on the septum, and maybe it might be in the only place remaining would be in the right ventricular outflow tract. Your signal is just incredible there. The longer I look at it, the more I feel that we should just come on ablation here. Your ablation distal is quite early, and it is a complex signal. The signal below your ablation distal is actually ablation proximal. That also has that U-type signal followed by a ventricular bipolar signal. So I see there is some, local scar or delay or some complex signal there, which is causing that PVC. And the onset of the bipolar signal to the PVC, the timing appears to be quite nice and long. And when you compare it to the sinus rhythm QRS on the right of the screen, you can see there is a little bit of this chatter towards the end of the bipolar signal. And I wonder whether that is all coming in earlier, kind of a reversal of that sequence. But this looks really good. Another thing I kind of look at this is I want to make sure I don't see any far field atrial signal, because if you see that A is artery and you don't want to ablate the artery next to it. So, here I feel pretty okay if we come on ablation, but signals certainly look very, very interesting and very, very enticing.
Agree. I think signals are really early and you've bracketed it well. And again, I think Abhishek will have more to say about how much and where to go and how he would plan for some of these procedures, but clearly you're way early. And I do see some chatter, I like to call it, that comes in late. So there's something else going on after your initial signals, but you're really, really far ahead, but there's got to be some reason you're showing us this.
Yes. So, in a young patient, whenever we think of outflow tract, we're trying to just look for earlier than the QRS. So that's been our go-to strategy for outflow tract idiopathic young patients. But in older patients, with the outflow tract morphology, fixed coupling interval, it's not always triggered activity is the mechanism. As Dr. Kolge is pointing out, we have this signal, way out in diastole. But when this signal doesn't cause the second component of the electrogram, you don't have a PVC. So this could be a very late, delayed diastolic signal somehow in the outflow tract, it is able to re-excite the heart, you have a PVC. So this is an example of, thinking about re-entrant mechanism of a PVC. Very long delay. If it's able to re-excite here, you have a PVC. You'll still have to do mapping to define the circuit. But whenever you see these long delayed signals, think about re-entry as the mechanism and not triggered activity.
Great. Siva, just one question I had. You pointed out that this could be, if you can see what I've drawn, could be like a blocked ectopy. But how can we be sure that it is not like a valve artifact from the pulmonic valve if you're in that particular location? Any tricks you can share with us?
So usually the valve artifact will be on top of the T wave, but many of these cases we have an intracardiac ultrasound catheter, and you can see whether that artifact on the valve closure is happening on time with the signal or not, or whether the valve is actually making the catheter move. Usually the valve artifact signals are, right at the peak of the T wave around there, not so late.
Mm-hmm.
Okay.
And plus it looks quite far field, this signal, like a valve artifact, because it is hitting the catheter might just look more sharper and more near field. But this just looks a little bit more blunted and far field. Yeah. And the definitive, the proof is if you diagnose re-entry and if you ablate a very late area, usually that signal goes away. Whereas a mechanical artifact by ablation, it typically doesn't go away. A late activation beat, if it is a cause of the PVCs, with ablation, the beats go away and the signal also goes away. Nice.
Okay. And another example is in this is an example from a different patient. Again, the re-entrant outflow tract morphology beats. You can see very similar examples. Late diastolic signals. If it is able to re-excite the heart, you have outflow tract morphology. Here you have that late diastolic with block to the myocardium, and then you don't have the PVCs. So this is proof that this late delayed activation is indeed participating in the cause of those PVCs.
In Abhishek, the one thing you mentioned, I think is worth reiterating. You said if you're in the outflow tracts and you see atrial signal where you're not expecting it, what does that make you really nervous about, and what should that make everyone really nervous about?
So first of all, two places as you're going into the RVOT, you may see the A signal. One would be as you're just crossing the His area, you would see A, His, and V. Obviously, you can't really justify ablating that area. But when you climb up into the outflow tract beyond the pulmonic valve and you're looking more septally, that's where your left main is going to be. And the structure, another structure close to it is the left atrial appendage. So you're going to get that far field atrial signal from the left atrial appendage. And if you see that, then that's just your marker that you're very close to the left main, and let's not ablate that. In your case in point, whenever we are doing, say, retrograde approach for PVC mapping or VT mapping, I don't want any of us to try it, but sometimes the catheter by accident goes into the left main. Just pay attention to the signal there. You'll see a big A and a V signal both. And that A is, or the near field A signal, what you see in the left main again is from the left atrial appendage. So whenever I see any A, I just think if A is artery and A is asirvatam, and he'll look at us and say, what the hell are we doing here? So I would just not ablate anything which looks like an A signal in the outflow tract.
Exactly. And for the A, I'll make it would be angiogram.
Exactly.
You have to explain that A if you see that A. Sometimes you'll also see this if you're kind of at that left cusp, right cusp junction or below, and you're kind of slipping a little bit too close to the left atrium. That's a little bit more safer because you're going to be below the cusp. But anytime you see an A on your signal anywhere, the other thing is, can you be creeping towards the non-cusp? And then if you're near the right non-cusp where the penetrating bundle of His is, you want to stay away from that. So any A signal up there, you've got to explain it. You've got to convince yourself why you're seeing it. If that's an angiogram, do not just rely on ice. If that's an angiogram or you have to maneuver the catheters, you need to do that.
Great.
Very nice.
And this is the schema how this can happen. So sometimes when you have a slowly conducting zone that's able to somehow come back and re-excite the myocardium, in the outflow tract, it's sometimes very hard to delineate the complete circuit. And sometimes you may find just the area of delayed activation. So finding that very late delayed activation would be a target rather than early systolic activation. So sometimes if you try to target here, if you don't get rid of the delayed zone, you may have a different morphology PVC. The clues here are usually this is in older patients, and fixed coupling interval is what we see. Fixed coupling interval, you have to think about re-entry in these patients.
Siva, when you're mapping in this area above the pulmonic valve, at least sometimes I get a tendency that the catheter just keeps slipping out above the valve, below the valve, and then you lose your position. Any tricks you have to make sure that you have like a really good contact in that in the suprapulmonary space?
Yeah, so first, whenever we're doing this outflow tract PVCs, having an intracardiac ultrasound is key to understand where your catheter is. Do you have adequate contact or not? Sometimes on fluoroscopy, you think that you may be somewhere, but when you actually look on ultrasound, you are somewhere else, either above the valve, below the valve. So I think having an intracardiac ultrasound for all these difficult cases is key for success. Now, specifically, having contact in these cusps or above the cusps, if you want to map inside the cusp, if you're coming from below and going straight at it, you have to heat up the cusp and the tissue behind it. Some of the other colleagues have described taking up a catheter into the pulmonary artery, making a U shape and trying to map it in a reverse curl direction. That's something you could do. You have to use a tighter curve, like a B or a D curve. So it actually curves and you're mapping with this end of the catheter.
Great points.
So I think if I can make a few points. So there's nothing in EP that's a straightforward procedure, slam dunk procedure, garden variety, RVOT. To me, I think you should remain terrified of anything on the anterior RVOT. I think that's a spot you've got to be really focused. You got to be hyper focused in the EP lab at all time, but you got to be Michael Jordan Game 6 Utah Jazz focused when you're on the anterior RVOT, because the perforation risk is very high. And that area right there is just, you're looking for trouble. It's just really, really careful movements. So Abhishek, can you walk us through maybe how you get up to the anterior RVOT? What tips, what tricks? Should anybody be pushing anything? Should anybody have their ice catheter a certain way? Walk us through this, because I think this would be tremendous benefit to all the listeners and viewers.
Sure. So what I use is I use an irrigated catheter always for mapping and ablating any of the outflow tract PVCs and VTs, because it's also important when we go to the LVOT side that we have an irrigation going on to prevent stroke and everything else. Then I generally use an SRO sheath while going into the outflow tract. I get the catheter, I get the sheath up, then I get the catheter up. I mark my His bundle location. I'm not, I generally don't put all the catheters what Siva does, because I just want to prevent any chance of perforation with extra catheters, especially sometimes you have to give isopril and everything else. And then I advance the catheter in, and then I try to clock the catheter and the sheath, making the tip look up. When it goes up, I don't just advance the catheter in directly. I make sure on ice that the catheter is not touching any surface. And then I gently advance the catheter up. And I try to advance the catheter up under ice to a place which is going above the pulmonic valve. So then I know where the pulmonic valve is. In RVOT and in life, it's easy to go from top to bottom than to go from bottom to top. So once you're above the valve, then it's easier to come down. And then I just make like a quadrant type of a move. I go left, I go right, I go back, I go front. So I just make like a circle around it. And then as we are going at different levels, once we start to see any good signals, then I kind of zone on into that area. If I'm at that location, what you're showing on the RVOT, then the 2-3 challenges there, one of them which Siva alluded, is that if the catheter is above the pulmonic valve and then it comes down, you lose that, if you're above, you're here, and then you lose that position, then you're going to slip down here again. So at least what I do, I try my best to remain above the leaflets, map, and then gently just undeflect so that it automatically falls below the cusp, below the leaflet, and then try to map here. What power would you use here, Chris?
Yeah, I'll tell you about that. I just want to just hit on one thing. I think this is a multi-person job. You need someone to work the ice while you're making these fine movements. And what I try to do is, as I'm going through the RVN flow all the way up to the outflow tracks, just as you mentioned, I try to watch my catheter. So I'm hugging the septum, almost like I'm hugging and wrapping right around that infundibulum. So I'm hugging where the aorta is. Now, I'm not pressing too hard because remember, once you get higher up, there's nothing covering you like a quote septum posterior. Right. But exactly like you mentioned, I don't want any resistance at any time. I go as high as I can, and then I come down.
Yeah.
So that I think is really key. And I'm watching this on ice all the time. And as you just, the question now, I'll get to your next question about the powers. I stay no more than 25 to 30 watts at this region.
Right.
Very, very careful. I've never gone above 35 watts here.
Yeah.
I'm more than happy to stay with ablation, 30 seconds, come off, wait till I've got all this region nice and ablated. I don't want any steam pops here. It'll be catastrophic.
Yeah.
So I don't want anything like that. Then I have 3 eyes going on. One eyeball is looking at the ice. Another eyeball is looking at the impedance. And another eyeball is looking at the electrogram. It's critical. You need to do that. Fellow, whoever's with you, everybody that's in the room has to be very, very locked in here because it's a very dangerous place.
I have seen personally few cases who have gone to the OR after a successful ablation just because there was a pop or something like a big, perforation in this location. It's very hard to, just keep on draining it in that particular location. So, today is the time of taking pictures and selfies and everything else. When do you actually fluoro this and when do you cine this?
So when I'm in there, I'm in a whole nother zone. I'm not interested in images for webinars or case reports or Twitter, none of that stuff. What I do when the job's done, when the ablation's finished, PVCs are gone, leave the catheter right where it last was, then someone could take the cine so I don't have to move at all, or whoever else is in the room, I'll have them take the cine as well. Never am I taking my eyes off of those 3 things I told you to do a cine. That's not good for the patient. That's not good for safety.
Yeah, same thing I do. Same thing I do. I don't even do a lot of fluoro for AV and RT. I'm just looking for the signal. If you see a far field haze, you see the A getting bigger, then you have to stop. So key thing that we have to focus really well on the signal and the impedance.
Now, one other area too, from Siva's beautiful ice images, beautiful. And I learned this from Siva because he's EP 601, right? He's at another level. But that ice image that he's showing you right there, that muscle tissue, when we get these referrals or redos and all of these things, when we get that area, it's usually never one spot. And I learned this from Siva on many occasions. You usually have to create an arc type of lesion. Siva, do you want to tell us your approach in this area? Like muscle sleeves, signals, timings, pace mapping, how that could lead you astray. Give us some knowledge here.
Yeah, so I think if it's a difficult case, you have to, ICE actually provides you good clues. Are there these bundles that are going about leaflets? So for example, if I look at this ICE view here, the aortic valve is here, and this is the pulmonic valve. And pay attention to this. There's a little muscle bundle that kind of goes above the cusp. So here, the ICE catheter or the ablation catheter is kind of straddling the cusp and trying to touch that muscle bundle. And you may or may not get good catheter contact this way because the leaflet is trying to push away the catheter. And you can come proximally, and you can also have success by ablating that muscle bundle, below the valve, but this may require 3 or 4 lesions rather than just 1 or 2 lesions above the valve. So ICE, it gives you an understanding of this continuity of these muscle sleeves.
That's amazing.
Sometimes too, I think you need to go a little bit left and right, or septal and lateral, depending on how you're looking, because the muscle can arc.
One question is, when should a patient who is getting an RVOT PVC get an angiogram? One situation where you would always do an angiogram.
So in the catheter where it is, I would not do an angiogram. But if the catheter was more kind of in this particular location, 100% I'm going to do an angiogram, if you could see that. So I would definitely do an angiogram there. And and that's the place where you're going to see that far field A signal. So definitely in that location. Below the pulmonic valve, generally I would not do an angiogram.
Yeah.
So for me, right where Siva's showing the ICE image, if I'm on that anterior wall and I could see where I'm there, I don't do a coronary angiogram. If I'm posterior, I'm born of Sam Ashervatham, I am doing a coronary angiogram or I'm not burning. That's just clear and simple. Even if I could see on ICE and trace the entire coronary anatomy, I do not care. Posterior RVOT, angiograms happening, or I do not ablate.
Yeah, that's the closest side, closest side to the left main area, posterior RVOT, and that's a key point to remember.
Great.
So with this, I think this is Dr. Deshmukh's case. He's got a very interesting case here. I would let him present the details of this case, and he will take us through this particular tracing.
All right. So this was the teaser what we had sent out, but basically, can you advance the slide, Chris? But basically, a young man was having frequent symptomatic PVCs during exertion. And I did all the tricks what I learned from Siva. I except of doing a transeptal in the clinic to measure the A wave and the V wave, I did everything else. And we were convinced that this patient was symptomatic and also had PVC mediated cardiomyopathy. So in this setting, we brought him to the EP lab. So based on this morphology, Chris, where do you think you are? Would you map the right ventricle, left ventricle? What's your initial strategy?
So to me, looking at this, V1, I have maybe a tiny R, but more of a tiny Q, but more of a broad R. So we got right bundle, clear superior axis. I think, I can't tell if 2 or 3 have any discordance. I think they're almost equally superiorly directed. 1 gives me a nice little clue. There's an RS. So I'm thinking something's might not just be septal, but or at least starts something and then exits more laterally. And then I definitely see it on V4, V5, V6. So to me, I'm thinking PAP muscle. I don't know how close the posterior medial or the anterior lateral, but I'm going exactly right to the LV. I'm not wasting time in the RV.
Yeah, same with me. Whenever I see, it's like, if you know where it is coming from, I also try my best to go straight to that location without mapping at a lot of other places, just because the key thing is really going to be a good activation map. And then once, sedation starts and patient starts to move and we give more propofol and all these things, I'm very, very concerned that the PVC would go away. And that would be a shame. So I also go straight to where I think this PVC is coming from. And then, you can spend the time for more detailed mapping. Siva, in your own approach, if we think this is coming from the LV PAP muscle, what's your access preference? Do you go normally transeptal or retrograde? I know you have had some cases of transapical puncture also, but just generally, would you go transeptal or retrograde as a start?
So in general, we are more used to transeptal punctures, and we try to avoid arterial access complications. Young patient, you could go either way. In some patients, you may need mapping from both routes to have a complete map. But, young guy, maybe try a transeptal route first. And if you're not getting good contact based on ice or not getting good numbers, you try the other way. They're both complementary. One is not better than the other, just complementary, depending on your ease in the lab and what you want to do in the lab.
Agree. I think this has also been an evolution, back in the day, when people are ablating left lateral pathways by retrograde approach. And now, because we are so facile with the left atrial mapping, with all the AF ablations, what we do, and the transeptal punctures, what we perform, certainly my also access of choice to get into the LV is a transeptal puncture. And certainly I'll use a steerable sheath so that can help us, move around the left ventricle a little bit better.
Now, what I notice here is,
oops, sorry, go ahead. Go ahead, Siva.
what I notice here is the coupling interval is quite long. So this is less likely to be like a triggered automaticity, more like an abnormal automaticity rather than triggered activity here, consistent with the papillary muscle arrhythmias.
Great.
I think one point to make, even if they're young or old, you still run into issues with retrograde. So I always want to have both options available, retrograde and transeptal, but I try as much as I can to use transeptal. The reason being, if they're younger, usually they'll have smaller aorta, and it's really hard to make that curve and prolapse safely. So I'm just worried going up the aorta with them. If they're older, I'm worried about knocking off calcium or any type of plaque. So my go-to first stage, I got to really have that option there, but I really want to go transeptal if I could, if I'm going not in the outflow tracks. If I need to map above the aortic cusps and I don't have a mechanical valve or something else blocking me, then I'll try to do transeptal.
So Chris, one question we have is, how did you narrow on the papillary muscle? Can you reason us what made you think it is a papillary muscle based on the ECG?
Sure. And again, all of these are exits of where our PVCs are coming from. This is where I'm thinking of going to. Still got to do the fine mapping, but the clues are, if we're saying this is right bundle. And again, I don't want to do any pattern memorization, looking at broad R wave and V1 or all these memorization things. I don't do that. So I look at V1, right bundle. I start thinking, okay, I'm looking to the left ventricle. I see 2 and 3. They're really strongly superior axis. So I'm thinking somewhere low in the left ventricle, opposite of what you would see in the outflow tracks. I always try to gauge between 2 and 3 to see if there's a discordance. Sometimes if you're closer to the septum and you're closer to lead 3, then you'll be more negative in lead 3. If you're more on the free wall or the lateral wall and away from the septum, you'll be more negative in 2 because you're coming away from that lead. Here, I don't really get that information. Then I look at lead 1. Initially, it's positive, but then there's an S wave, so it's going away from it. So there, it kind of doesn't tell me exactly where we're at, but it gives me a clue that maybe I'm exiting somewhere, at least going away from the lateral wall towards the end. But really what started me tipping off more is when I see that RS, especially in V4, V5, and V6. I guess if I had to do any type of pattern recognition, it's sort of that. If they're flatter, as Abhishek mentioned earlier, I think of precordial concordance being at the base. But when you see that RS, V4, V5, V6, you got to think something's around the mid to lower part of the LV cavity as you're going towards the apex. And then you have to kind of go towards the V4, V5, 6 lead and then go away from it. Yeah. So that's really what tips me off, that this is probably anterolateral pap muscle. Nice. I'm at least going to be interested in mapping those very closely.
So right. Inferolateral?
Posteromedial pap muscle, right? Or inferolateral?
Posteromedial because of, sorry. Posteromedial because that initial lead 1 is positive.
Great. Yeah. Perfect.
I think to hone in the point, if you V1 to V6 all positive, it's basal. V1 to V6 all negative, apical. And if you have a transition, V1 to V4 are positive and V5, V6 are becoming more negative, think about mid LV. One structure that's there in the mid LV is the papillary muscle.
Great. Perfect. All right, we will keep going. Chris, can you move the next slide?
Absolutely, I can. Oh,
so then,
beautiful.
Then we see this signal. And this looks like a great juicy signal. would you come on ablation here or no? And I can tell you, once I saw a signal which was kind of minus 48 millisecond. Either I'm dreaming about this signal, or this is like, I'm really lucky that I ended up on a great spot here. So I came on ablation, and nothing really happened. Keep going. You have the control of the slide.
I have to admit, I would come on too, because it just
Keep
looks
going,
too.
yeah.
All right.
And then we map more, and we start to get even better signals, like 52 milliseconds ahead. And even if you see the local signal, it is quite fractionated. So we know that this is kind of a diseased area, maybe even a little bit of a signal here. So when I put the ICE catheter in, first thing I do when I look at the papillary muscles is that in my own mind, I think that it is really not a posteromedial and an anterolateral papillary muscle. It is kind of a network. It's a mess out there. And all of them have different heads. Anterolateral papillary muscle for that patient may have 3 heads. Posteromedial may have 5 heads. Who knows? So first I do is try to see if I see any funny calcium on these papillary muscle. Is some part of that papillary muscle more bright than usual? And then in my mind, if I think that the ECG is kind of suggestive that the PVC can come from that particular location. Once I know that, then I put the ablation catheter there as we are mapping these PVCs, and then try to see if we can find that perfect spot where we could ablate this particular PVC. But as Siva pointed out initially, as again, Siva is EP601, that this was not like an automatic PVC in a normal heart, because he pointed out that the coupling interval was so long. So I had that in my mind, and I was looking for any abnormal signals, what I could see on the pap muscle.
Sometimes do you also look at the mitral valve itself to see if there's any contact areas? I think that's what gives rise to the echogenicity, or maybe those calcifications. But are you honed into that?
Yeah, I do. And especially when people have mitral valve prolapse, it even like tries to hit the leaflet, kind of hits the pap muscle even more. And then they can have a local re-entry and cause VTVF from that particular location. So again, when I'm preparing, I make sure there is no mitral valve prolapse, there is no mitral annular disjunction and all those things, so that, that's not creating that mechanical irritation in that particular location.
Amazing.
Can you go to the next slide? Yeah.
Absolutely.
Go next again. Maybe show us the ICE image.
Yes.
On the next one. Good. Can you play this? Good. So this was the area where we felt that the best signals were seeing there. And if you just keep playing the ICE again, you would see that we are ablating pretty well there. We are almost creating a lesion next. But the catheter keeps on slipping on the head of the papillary muscle. So that whenever that seems to happen, and if I know that I'm in a good spot, but the catheter keeps on flipping, then I just change I just go to cryo, because the only way cryo can ablate is that if it is stuck to that tissue. So if the cryo catheter, if I can get it at the same spot, get it stuck on that same head of the papillary muscle, and if we give energy there, I think we are going to take care of this PVC.
So Abhishek, let me ask you about that. How do you know you're not making good contact? And how do you know you're slipping?
So
you're mapping.
If you think you're at the right spot with the signal, which is 50 millisecond ahead, and if you're not able to ablate that, you have to make sure that, whether you're really giving good energy. So on intracardiac echo, I saw that the catheter was kept on flipping and was not really making good contact. That is a clue. The second clue is that, if you're not making a good lesion, no matter how good the mapping is, we are here to ablate. And if we can't ablate, then the PVC is never going to go away. You can't go and show the patient that I was 50 milliseconds ahead and then I couldn't ablate, and then that becomes a problem. So that's why I try my best to, once I have the mapping done, try my best to see how I can deliver good energy. I start 30-35 watts in that particular location. And then I think that sometimes is enough. If I believe based on mapping that the focus might be more deeper intramural, then can certainly go 40-45 watts, but generally don't want to go much higher than that.
Excellent.
So we
what
have
are you worried about going higher than that?
So, there's a problem, because you could have a steam pop and, you could infarct the papillary muscle. And then, the two things that can happen, you can create a wide open MR mitral regurgitation, or even that denuded tissue can go into the brain and give a stroke. So you don't want any of those two things to happen. So again, looking at the impedance like a hawk to make sure that we don't have any changes in the impedance. For cryo, it is more forgiving. You are never going to have a steam pop with cryo because you're really not heating anything. So, cryo, I give like 4-minute lesion, make sure that the temperature is nicely dropping, and then you can actually see good lesions on the pap muscle with cryo.
So Abhishek, this is one more reason to go transeptal. It's very hard to take a cryo catheter retrogradely. It's a much stiffer catheter. And I think having a deflectable sheath helps you get that cryo catheter to the area of interest. We have a hand raise from Faisal Mato. Maybe if you want to ask a question.
I'm not sure we're able to do that, but Faisal, if you put it through the Q&A, we could read your question out loud.
There's one more question. Do you use 2 axes into the LV, one for multi-electrode mapping and one for ablation catheter? I don't. If I have one transeptal, I just, if I'm using multi-electrode mapping, I just map with that catheter, and then I put the ablation, I take that catheter out and put the ablation through the same sheath. I don't do multiple axes.
Same thing. I'll take just one axis. I'll do my mapping. And remember, you're not going to see the same signals that you did on the multipolar. So I make my annotations on that map. I go to it, but just like Abhishek was showing you, really, really critical thing is on ice. Now, did we get all the questions? Is there any other questions now?
Nope, we got all the questions.
Okay. The other thing is, how do you know when not to use cryo? So just to tell you what I've been doing, especially the last 4 to 6 months, is I've been doing the radio frequency. Even if I see the PVCs go away, I'm still not sure, or if I see I've modified the exit, I'm still not sure that it's completely gone. So I've had a low threshold to take out the cryo. Again, just like Siva mentioned, I've never put a cryo catheter across the aortic valve. I've never done it retrograde, always transeptal. But I've been starting to put the cryo so I could get the tip. I don't know if it's you're getting the base and that's where the initial PVC exit is, and then once you've ablated that, then your exit's at the tip. But I've noticed in some cases that I've done really good ablation around the base, and then I'll see a variant or that same PVC sort of comes back later on during washout, and it'll be at the tip, and then I pull my cryo out. You guys have seen that or can explain that?
Yeah,
sorry, go ahead, Siva. Yeah.
With the RF, as Abhishek mentioned, it's contact, some tissue edema. You can change your exit site. So cryo gives you that finer contact for, creating that lesion formation, especially much more stable at the tip of the papillary muscle compared to the RF catheter.
Excellent.
I have been using cryo for practically all my cases. After the RF is done, I still go there. I just have this OCD that the PVC shouldn't come back if possible. So I do my best and then put cryo there again, because it's hard to get, like, even if you believe the contact force technology, it's hard to get like amazing contact on the tip of the pap muscle. You can certainly wedge the catheter at the base of the pap muscle, but on the tip of the pap muscle, it's very hard to get a good contact. So I like to use cryo, after the RF is done. Yeah.
Very careful wedging. Either this is one key. I'm always careful wedging. Either it's between 2 of the tips of the papillary muscle heads, as you mentioned, they could come trifid, bifid, or at the base. Wedging, then I'm really nervous about steam pop. That's where you got to be. Again, you should always be honed in on the signal and impedance, but you got to be really, really careful. It's whenever that catheter gets trapped and there's low flow, that's when there's issues. But I agree, cryo, I've basically done almost every. I'll start with RF, probably because I want to see if I could get a good enough lesion. And I think I have on some, but also because that's what I'm using my mapping for at that area anyways.
Another thing is, whenever we are ablating with RF in this location, I have one of our nurses or techs stand by the Zoll or a defibrillator to give a shock, because it's not uncommon that you could have VF when you're ablating there. And Guru, our future colleague, is going to say, he just said that if you use cryo, then less chance of VF, which I also agree that it's less chance of VF if you're using cryo. but you're going to map with the ablation catheter. You're just going to get better mapping with the ablation catheter, RF catheter. So.
And let me add to that point, Abhishek, say you came on in that RF and you started to see, polymorphic or VF, what do you do?
It all depends. I sometimes try to ablate through it, but once I see that it's, from the polymorphic stuff, it becomes VF, then I just come off, have them defibrillate, wait, make sure everything is okay, and then, start again.
Good. Same thing. I try to ablate through it. So, because sometimes you can get into a really bad storm when we are in this Purkinje myocardial area. You could have bad things. So I try to ablate through it, and try to keep it safe, but that's what I try to do as well. And then I'll come off cardiovert if I can't get to it. But maybe sometimes your best weapon in that issue is not just defib, it's burning.
Yeah. Great.
All right. Well, it's 115 degrees outside. It's June. We've all been locked up for a year and a half. We don't want to overextend and keep anybody longer than we need to. We really appreciate your attention, and I'd really love to thank Abhishek Deshmukh and Siva Malparu, who are just expert ablationists, for their insight and journey with us tonight and in the seminar. And for everyone out there, thank you so much for joining us. This will be taped. This will be put on YouTube as well as our CVCME website. And we will get to all the questions you have, as well as all the questions you've asked us via our CV webinar email inbox. You have our emails. You contact us at any time you have any questions or want to run by any cases by us at all. And I think I speak through the three of us to say this is a lot of fun. Thank you so much. And we look forward to maybe doing this again on a different topic.
Great. Thanks a lot, everybody.
Thank you, Chris, and thank you everyone for attending.